All right, so let's see how much we can go with the rest of in half an hour or so with the rest of the section. Uh, there are certainly anemia. I think broadly we can say the red blood cell is normal but become anemic. Blood loss is one of them. Hemolysis. We're going to see that some of the hemolysis associated with like DIC, for example, or TTP, for example. Um, uh, Chronic disease, myelothixic meaning that somehow the bone marrow is crowded out in the case of, say, cancer, for example. Um, and well, most of these, let's say, blood loss, hemolysis, chronic diseases often associate with the red blood cell themselves, right? But myelothixic and aplastic anemia, in this case, myelothixic is due to um, this right here, due to the loss of the bone marrow. Okay, by you have cancer cell invading, or just the blood cell cancered out. So the idea is basically it just crowd out. Right? There's so much cells in the bone marrow, it just don't have the normal level. Aplastic anemia that you often see is associated with, say, um, let's say chemotherapy, for example. Um, how about we call this radiation, for example. So it could be part related to chemotherapy. So in this case, what happened is that you're destroying the stem cell. So if you don't have the stem cell, everything will go down. So you can call that as uh, pancytopenia, right? So that's sorry, that should be penia. Um, right, so that meaning red blood cells goes down, white blood cell goes down, platelet goes down, everything goes down. So we call that pancytopenia. Um, and if it's related to blood loss, obviously blood volume would decrease. You will, either internally, certainly outside you can see it, but internally you can't see it, but you can see the effect within 24 hours of blood loss immediately, right? Hemorrhage, for example, or some big one, hepatoma, if it's small one, petechia, but petechia you probably don't see any result. Um, Hemolytic anemia, this is destruction of the red blood cells, and you can see that's how you can distinguish between intravascular versus extravascular. I told you already, intravascular associated with this could be increased. So I don't know how it's messed up. Whenever you have a destruction of cell, any general cell, right, lactic dehydrogenase will go up. Okay, so LDH will go up. That you see that. But in this case, hemolytic anemia, you see this increase of unconjugated bilirubin, okay? Unconjugated in the blood. Decrease in haptoglobulin, and then you also see free hemoglobin in the blood and the urine, I told you before, right? In the blood, hemoglobinemia, or in the urine, hemoglobinuria, right? So just follow these. If I give you these characteristics, particularly decreasing level of haptoglobulin, that's my clue to tell you that's an intravascular hemolysis. Okay, so here are some of them that could be considered as intravascular or extravascular: spherocytosis, eleptocytosis, glucose 6-phosphate dehydrogenase, that's a very important one, sickle cell anemia, antibody mediated, for example, or non-antibody mediated. DIC, we'll talk about thrombolytic thrombocytopenia. This is due to a defective in enzyme that Adams 12 that sort of like breaks down von Willebrand von Willebrand's factors, so that it's important for coagulation, but you can't do that. Then you get pretty much destructions of the red blood cell. You can also see this PNH, proximal nocturnal hemoglobinia. Proximal means sudden, nocturnal means usually night. This is usually defected in one of the anchoring proteins in the blood plasma membrane. And if you have a defective, then it basically get destroyed, if you will. Okay. Hereditary hemolytic anemia, hereditary spherocytosis is missing the spectrin or ankyn, and that's often associated with extravascular. The membrane is more fragile. So instead of living for 120 days, their survival doesn't reach 120 days, for example, and they get destroyed in the spleen. Hereditary eleptocytosis, asymptomatic acanthocytosis is basically they're also lipid bilayer. They form a spinal process. Okay. Spherocytosis is an important one to know. Okay. So I would circle that. That will probably be a good example to differentiate between vascular, intravascular, extravascular. All the other ones just fall within this one class. Glucose 6-phosphate dehydrogenase is an enzyme that often sees in the blood, and it's important for making glucose 6-phosphate, which is important for the pentophosphate pathway. If you don't know what that is, it's the important for making the sugar base for the nucleotide, what do you need to know with the glucose 6-phosphate dehydrogenase? Earlier when we were talking about Heinz body, which is these insoluble substance in the red blood cell, could be considered as the hemoglobin BART. Your body or the cell itself that has the redox potential, how much oxygen, NADH positive versus, NADH or NAD positive. Okay, it's essentially a way of the cells to say, oh, how much oxidation you have, and so that redox potential is regulated by the glutathione, basically. Okay, and glucose 6-phosphate dehydrogenase play in that roles of glutathione. What's the take-home message? Okay, take-home message is this: that in people who has glucose 6-phosphate dehydrogenase, if you look at the red blood cell, right, oftentimes you see a Heinz body, right, which is that insoluble substance in the red blood cell, and particularly when there's a lot of oxidative stress, for example. Think of it when these people take on medication. Okay? So things like anti-malaria drugs, or maybe antibiotic, medication like pain medication, and the non-sulfa. So my clue is that when the person take on these drugs, right? Anti-malaria drug, antibiotic, and then they started to have the destructions of the red blood cell. And one of the characteristic of red blood cell is that you start seeing, let's say, okay, oxidative stress. You, oh yeah, hemoglobin, Bart, right? Another type of hemolytic anemia is sickle cell anemia. Uh, Sickle cell anemia has a defect in the globin gene. Okay, it's a single change of nucleotide so that the amino acid glutamine is converted to valine. Glutamine is a charged molecule. Valine is a non-charged molecule. Right? We're talking about the side change here. As a charged molecule, this is a sorry, it's charged. All right. And this is, so charged meaning that it's polar. Okay, it has a polar side change. This right here is non-polar. So if you want, you can say, okay, every amino acid has this acid and the amine group, NH amine group here. That's an H. And for valine, there's a different side chain. So valine will look something like this. Okay, that's a valine. All right. So this is a non-polar. Right. It's for glutamate is it's a charged molecule like that. That's an acid. That's the amine group. And this is a side change of this. Okay. This is a side change, but this is right here is non-polar, but this is sorry. This is non-polar, and this is a polar molecule. See this charge? What's the point? The point is this. Okay. As a polar molecule, so here's a globin. So let's say this is hypothetically a beta globulin. Well, if its amino acid is glutamine, it's going to glutamate. It's going to stick on the outside like this. Okay, so it can interact with water because it's a charged molecule. Now, if it's changed now to valine, then it's non-polar, so it doesn't want to be interact with water, right? And so what happened then is that you will see that valine now is internal. So the conformation of change, so this one amino acid change really changes the structure of the beta globulin. And so that in patients with sickle cell anemia, under a hypoxia condition, the globin is actually now, that it looks more like a sickle, like this. And that is the red, this is the structure of the red blood cell. The red blood cell will look like this instead of red blood cell looks like that. Right? And that's because the globins in here is forming a polymer. And then because, they're forming a polymer and they kind of get stick together like that. This is also extravascular hemolysis. And oftentimes it's you get the sickles in one of the blood vessel. Downstream of that, they don't get enough oxygens and nutrients. They're going to die, and that's very, extremely painful. Um, okay. Sickle cell's anemia, you can see over here, it's gangrene in toes. Sometimes you have to amputate, yeah, you amputate the extremity if you can. Um, yeah, there you can do a plasmapheresis. You can actually change the blood or give them new blood, for example. But oftentimes sickle cell anemia patient is that as they get more blood, their potential in their body, the immune system starts seeing something that is different, strange, and then they're going to build an immune response to that. So that you get more blood, even though red blood cell, O blood, there's still small antigen on the surface. The body, their body can make the antibody toward that small one. So progressively, it's harder to find the right blood, even the O type, to give to them. Um, Okay, so in general, I'm not going to talk about these. There are antibody that is made, it's either cold antibody or warm antibody, that is can destroy the red blood cell, for example. Okay. Um, Maybe would you be able to associate between if I say, okay, cold antibody, that means you get a reaction at 4 degree as opposed to warm antibody at 37 degree. We'll make it easy and say, okay, for if it's related to warm antibody, it's more extravascular. If it's cold antibody, it's more intravascular. Okay. Um, Transfusion, hemolytic, of course, if your blood type is A, you should get only A or O blood. But if you're getting um, B blood, then you get preformed antibody, particularly your IgM, can react to that transfusion reaction. Hemolytic disease of newborn, we already talked about that, which usually the mother is Rh negative, who's carrying Rh positive child in the second pregnancy. Because her first pregnancy, her body is exposure so that she makes the antibody, but you can block that, uh, prevent her from seroconverted if you give her RhoGAM. Um, Non-immune hemolytic anemia, and there are other ways that it's non-immune. We can talk about is DIC, TTP. You can see here. Okay, this is non-immune. DIC we're talking about is that disseminated intravascular coagulation. So we talk about endothelial cells should be, or the endothelial lining should be nice and smooth, but you start to see this coagulation, also known as consumption, because it's used up all the um, factor that is important for coagulation. But you start seeing these coagulated clots, and then as the red blood cell passes through that, that's how you destroy it. TTP, we're talking about, there's defect in this enzyme. What this enzyme does is it breaks down these von Willebrand factor, as you and this is important for coagulation too. But if you don't have this, you have this large molecule. As red blood cells passes through that, it could be destroyed. Okay. And the proximal, I told you that they're defective in an anchorage proteins of plasma membrane, so that they tend to destroy in the red blood cell. And it's usually when they're stressed, right? It's complicated stress that it has sudden, because that's proximal. Nocturnal mean usually night hemoglobinuria. Um, okay, so in all that, it's pretty much is intravascular, right? Because you see all the structure here is inside the red blood cell. And the intravascular, and you'd say that intravascular heptoglobulin decrease, lactic dehydrogenase is increased, that's already given. Free hemoglobin, unconjugated oxidated hemoglobin. And you can see that hemoglobin in the blood increase and hemoglobins in the urine. Anemia, chronic diseases, we talked about already. IL-16 alpha, usually that's increased, that is chronic disease. Myelofixative, bone marrow is crowd out, destructions of the bone marrow. Everything what goes down, that pancytopenia, you can see that. Aplastic anemia, very common, is that, well, the majority of it is, we call it idiopathic. We don't know what causes that, but sometimes a lot of them is due to radiation. Aplastic anemia, you see this nice populations of cells in the bone marrow. Here you don't see it. Okay, so let's finish up with polycythemia, and then next week, an hour or so, I'm going to talk about white blood cell. Okay, acute versus chronic. Sort of like, whether it's lymphoblastic or lymphocytic, Hodgkin lymphoma, we talk about, and myeloproliferative disorder. We'll talk about that next week. Polycythemia is the opposite, of course, of anemia. Normal level is 47, it's higher than that, 55 is polycythemia. Relative here just meaning that, if someone is dehydrating, then, so that they're losing the fluid. So obviously, relatively, the percentage of cells within that less volumes of blood would be high, right? But we don't really count that. That's just relative. Now, absolutely, polycythemia primary here. You do see a lot of red blood cells in the bone marrow, but in this case, the primary is EPO independent, right? And this is usually that's cancer. It doesn't need EPO. Okay? And that's one of the four we consider as chronic myeloproliferative disorder. The other one that we, as part of that, that myeloproliferative disorder would be, say, primary primary myelofibrosis, for example, where there's a lot of fiber, it seems to be fiber in the bone marrow. There's also essential thrombocythemia, which is a lot of thrombocyte that you can see. And that's all part of the proliferative. This, and then another one, CML, chronic myelogenous leukemia, which is usually a translocation of chromosome 9 and 22. We're going to talk about that next week. Secondary is EPO dependent. I mean that people get polycythemia, but you can also look at, see their EPO in the blood is very high. There are some that is lung disease. Actually, we're going to talk about this next time. This is known as neoplastic syndrome. Neoplastic syndrome means that cancer cell put out EPO. Right? So you think of kidney putting out, or cells in the kidney put out EPO, but there are some cancer cell put out EPO as well. So then more EPO, more red blood cell. Let's say cancers, the cerebellum, hemangioma, cancers in the kidney, renal cell carcinoma. They are give an example where they put out a lot of EPO. And cigarette smoking, because of they're not oxygenated that blood very well, for example, then you can have secondary polycythemia. Secondary polycythemia, paraneoplastic syndrome, renal cell carcinoma. We're going to get back to this later on too, but this is also known as the great mimicker. So it's mimic a lot of condition, but they put out EPO, hepatocellular carcinoma, cerebellar hemangioma, uterine leiomyoma, uh, and again, when we talk about renal pathology, what happened is that one way, you know that the kidney, right? So if there's less blood flows to it, they can put out more EPO. Okay. But the kidney oftentimes will then make urine, and urine flows down to the ureter, which is then stores it in the urinary bladder, for example. In some cases, they have a defective urinary bladder. You can have the backward flow of urine. So then this area would look like large, we call that hydronephrosis. Okay. And so because you have a lot of fluid in this area, right? Urine backflow up, and that area that as the juxtaglomerular apparatus is there, juxtaglomerular cell that put out this renin and EPO. They might not see it a lot of blood supplies. Hence, they will put out more EPO, for example. And so, in non-neoplastic condition, hydronephrosis persists. All right, so I'm just going to be in it there. Then next week, in an hour or so, I'm going to talk about leukopenia, decreases white blood cell, leukocytosis increase, lymphadenopathy means just the lymph node would increase, for example. Some of this might be related to um, Hodgkin lymphoma, for example. Okay. Are there any questions? Okay, I'm going to stop the recording here then.